Dr. Mack Roach III.
My talk is really about clinical research and why it's necessary, important, and what needs to change. So I'm going to start with my take-home messages and close with my take-home messages. First of all, we do need more research, specifically in African-American men, to try to explain why prostate cancer is more common in African-American men. Nobody knows. We also need to understand the transition. Dr. Washington and Anika talked about the transition from active surveillance to aggressive treatment. You know, what can we do to slow that transition so that people can have long lives without any treatment? There's research that's starting to be done on how to prevent prostate cancer. I think that there are opportunities. For example, there's a cervical cancer vaccine to prevent cervical cancer. I think we need research on prostate cancer prevention vaccines. Some of the new technology in terms of the COVID vaccines may be relevant to cancer, and I think more efforts need to be made there. I'm going to talk a little bit about the participation in clinical trials and the distinction between what we call a registration study, which is a study being done to approve a new drug as a new indication for treatment, versus the cooperative group studies, which are more studies looking at standard treatments in a comparative way, and the importance that we actually are involved in those studies. And I'll explain why we need to be involved. And finally, the take-home message is that we need to empower more African-American researchers, because it's been my impression that we're better at taking care of ourselves than they are in taking care of us. So the reason that we're having this conversation in the first place, and this point has been made before, that if you look at Black people from poor counties or affluent counties compared to white people from poor counties or affluent counties, you can see there's still a much higher incidence and a higher mortality rate, and we don't know why. Now, there are people that would like to believe that, you know, this is just a genetic situation in which Black men are inherently more likely to get it, and it's really our fault because it's our genes that's causing this to happen. I won't dwell into this, but there's very little science behind the concept of race. We don't really know how to accurately define it, and the bottom line is that I don't think that race has a lot to do with there are not clear biologic differences, and I'll talk about that. So this is a paper that came out when I was recently on the faculty at UCSF. Actually, I've been on the faculty a few years. This was published in 1998, and this is about Kaiser. And so these investigators looked at the crude death rate among Kaiser whites versus Kaiser blacks, showing that Black people died at a lower rate, whether they were presented with local, regional, or distant disease. And interestingly, they also looked at non-Kaiser patients, and you can see that it was true of non-Kaiser patients too, that the mortality for non-Kaiser whites was lower than the mortality for non-Kaiser blacks. And they concluded that these findings are most consistent with the hypothesis of increased tumor virulence in Blacks. In other words, the cancer is just more aggressive in you guys, and that's why you guys are dying of prostate cancer. And one of the things that happened is I wrote a letter to this journal. This was the journal of the National Cancer Institute. And I argued that now what I did is I took their data from Kaiser and non-Kaiser and combined it and showed that the bottom line is that if you looked at the mortality in non-Kaiser whites, is very similar to Kaiser blacks. And so the argument that they made in their paper really didn't make sense to me. Are you saying that these people are biologically more alike because they have the similar mortality rate? And actually, I had other criticisms of their paper. They weren't happy about it, but it turned out that when you use this data, this is called SEER data, surveillance epidemiology end result data, you really cannot control for the quality of treatment. And so their paper assumed that if you have the same type of insurance, you're going to get the same type of care. And it's been known for a long time that that wasn't true. This is data from JAMA looking at revascularization procedures in Medicare A enrollees, and another paper looking at who gets cardiac catheterizations. There's always been and still continues to be differences in how Black and white people receive care, even if they have the same insurance. And if you look at that SEER data, here I just picked one year, the year 1988, and you look at the percentage of whites who received no treatment for prostate cancer in 1988, it was less than 40%, while Black men had, the majority of Black men received no treatment for prostate cancer in 1988. And this is not adjusted for when you look at data to try to say, well, what's the survival rate? Well, the survival rate really is not a fair comparison. So the best way to answer questions about the biology of prostate cancer and the issue of race is in studies where the patients are all enrolled, they sign a consent form, and their treatment is controlled for. And this table is very busy, but it really makes the point. These are 12 randomized trials where they took Black people and white people, they were stratified, enrolled, and they were followed prospectively. And of the 12 randomized trials, 8 of them concluded that race was not important. One of them concluded that African-American men did worse, and actually 3 of them suggested that African-American men did better. So the bottom line is that the preponderance of evidence from patients who receive the same quality of care for the same amount of cancer shows that race is not important and that prostate cancer is not inherently more aggressive in Black men. Now, coming back to the data that I presented, some of the stuff we talked about initially is that we know that African-American men make up about 15% of the population. But if you look at our representation especially in registration studies, now that previous slide were what we call cooperative group studies. These are studies that are brought to a broader audience. But in the registration domain, where they're now looking at experimental drugs, even though we make up about 15% of the population, our participation is dramatically lower, as low as 0.5% and as high as 8.5%. But basically less than half of what it ought to be. And so if we're going to have an opportunity to have access to new drugs, we also need to be involved because we need to establish how well they work. We need to be involved in trials so that there are enough of us so that meaningful things can be identified. And this is a paper that we just presented last month in Chicago, looking at artificial intelligence applied to over 5,000 patients and looking at the relevance of that artificial intelligence in the treatment of African-American men. Now, this NCCN stands for National Comprehensive Cancer Network. This is the standard way. The gray thing is the standard way that we use to predict how people should turn out. And we showed that with a multimodal artificial intelligence prognostic tool, we can improve our ability to predict how people should do when you're talking about metastases, recurrences, and death. So this is an improvement overall applied across the board to 5,600 patients. And we looked at, well, how well does it work in African Americans? And it turns out it works equally well as with African Americans, and confirmed once again that African American men did as well, in some ways slightly better. So without having African American men included in these studies, we would not be able to prove that it's not about the race, it's about the quality of care that really determines outcome. Now, part of the problem is if you look at the percentage of the number of medical school faculty by race, you can see that African-American men only make up about 2.9%. So you're talking about 15% of the population, very low numbers in participation and registration studies. And part of that is related to the fact that we have so few physicians on the faculty in cancer centers. And yet, when you look at if you look at the research being done, this is looking at genetics in terms of inheriting prostate cancer. What you see is that out of this was a consensus conference in 2017, only one African American was involved in this, even though prostate cancer is more common in African American men, which represented 1.7%. So even less than a 2.9% faculty, these researchers are not inviting African American researchers to participate, and so we're not well represented in this setting. Now, part of the issue of blaming race on the explanation for why African American men die at a higher rate is important because there's spillover. Once you start blaming survival from cancer, there are other ways that race is being applied. For example, there was a time where African American men were too dumb to play basketball. If you watch the championship, all the starters were African American. They said African American men were too dumb to play quarterback. If you looked at the Super Bowl a couple of years ago, 3 years ago or so, both of the quarterbacks were Black. Too dumb to play golf. I guess they had to wait for Tiger Woods to come along. Too dumb to be president. They had to wait for Barack to come along, and too dumb to play baseball. And this is my uncle Hank Aaron, who still holds the all-time run batted in baseball. So obviously these assumptions about race are not well justified. So how do we explain this excess incidence in prostate cancer? And in the interest of time, I'm going to speed through these slides. I believe that this is about stress and systematic generational oppression. And there are models. This is a model looking at mice, where they take two groups of mice, one group of mice that they allow to move inside of a confined space, and another group where these brass screws are applied to confine them into a very stressful situation. And what they've shown is that chronic daily stress versus, the more severe the chronic daily stress is in your life, the faster your tumor grows, the bigger the tumor nodules are, and so forth. And so I don't have time to go into detail, but I think that chronic racism in America, which is associated with a higher incidence of diabetes, hypertension, stroke, incarceration, unemployment, and also prostate cancer, I think that those things are related. So we know that prostate cancer is more common in African American men. We know we don't get as good a treatment, and we know we have an excess mortality rate. And so the question is, what do we do about it? First, we need more proposals, more research to explain why it's more common in African American men. We need to study this transition from active surveillance to aggressive treatment and how we can slow that progression. We need to do more work on preventing prostate cancer, because since it's more common in African American men, preventing it would have a more important impact on us. And we need to make sure that when they have new drugs, we need to have access to those drugs. And finally, we need to empower African American researchers to make sure that the questions that are most relevant to us are adequately addressed. And I'm going to close with this last slide. Of all forms of inequality, injustice in healthcare is the most shocking and the most inhumane. Thank you very much for allowing me to participate in this program.